So good evening, everyone. Thanks for logging into this evening's great session on men's health. My name's Tom Jarvis and I'm a functional, reconstructive and prosthetic urologist at Prince of Wales Private Hospital, also Prince of Wales Public Hospital and Chris O'Brien Lifehouse. I thought it'd be really interesting to speak tonight about erectile dysfunction because it's really one of those areas where GPs and urologists can work well together to deliver great results for men. The things that we're going to cover this evening, we're going to identify underlying comorbidities associated with ED, understand the variety and efficacy of common ED treatments, and make sure that you all feel very comfortable in managing men who present to you with erectile dysfunction. So erectile dysfunction is the recurrent or consistent inability to obtain and or maintain a penile erection sufficient for satisfactory sexual performance. Now, this is a definition that can obviously therefore mean something very different depending on the person or the situation. At the end of the day, it's a highly prevalent age-associated problem affecting a large proportion of men, and its prevalence increases with age. There was a study of over 100,000 men from Perth in 2013. That's probably the most recent and largest cohort to be studied in Australia. And these were all men over the age of 45. And the overall prevalence of ED in that group was 61%, which is a large amount. And of that group, of that 61%, 25% had mild symptoms, 19% had moderate symptoms, and 17% had what we'll call complete erectile dysfunction. If we look at how that breaks down with age, this is in healthy men without any other significant comorbidities. And you can see there's a fairly steep curve as people go from 45 to 85. But even at 45, you've got about 5%. By the time you hit 60, we're looking at about 25%. And then 85 or above 90. So significant number of men. If you add in some lifestyle risk factors like smoking, body mass index more than 25, consuming a significant amount of alcohol or sedentary lifestyle, you get a little bit more. If you throw in other diseases, maybe neurological diseases, endocrine concerns, and so on, you can see that those numbers significantly increase, but not as much as something like diabetes, which really lifts up the prevalence of ED for men and even young men. So those young men with diabetes, you've got a 25% chance of presenting with erectile dysfunction. So we've touched briefly on etiology, and I think there are a lot of different causes from erectile dysfunction, which is one of the challenges, because at the end of the day, the man just wants a firm erection that's satisfactory for intercourse, but there's lots and lots of reasons why he might be having issues. The most common are arterial supply, and we'll talk about this a little bit more in a minute. But you need strong and well-maintained venous drainage. So when you get the erection, you don't just lose it very quickly. You need a good neurological system so that you can have central problems, Parkinson's, spinal cord injuries, and so on. And you can have peripheral nerve problems. So things like diabetes, and that's probably where a significant amount of that causes effect. There can be endocrine issues, low testosterone of the aging male, rarer things in younger men, such as prolactinomas, thyroid conditions, and Cushing's disease. Erectile dysfunction may be drug-related. You often will have ED actually caused by things like antihypertensives or psychotropic medication. And this is often very challenging for someone like me because the patient has hypertension and they come and they say, could it be my medications? And well, it could be, but you probably need your antihypertensive or your medication to manage your anxiety. So unless they can be modified easily, often we're left with still having to treat the erectile dysfunction, even though the actual etiology might be able to be modified, but difficult to do so. There's psychogenic influences that can be situational, for example, a new partner, or generalized just due to something like a generalized anxiety disorder. And what can start off as erectile dysfunction for one of these reasons, it can often become mixed anyway, because of the effect, for example, that depression might have on someone who's gets erectile dysfunction, but then the depression worsens the erectile dysfunction. So you get in these positive feedback cycles that become difficult to break. At the end of the day, one of the major risk factors for erectile dysfunction is cardiovascular disease. And I guess you could say a way to the man's heart, maybe through his penis. I'll talk about this a little bit more. So cardiovascular disease and ED are significantly linked. First of all, they have all the same risk factors. So we've mentioned most of them: diabetes, smoking, alcohol use, hypertension, hyperlipidemia, age, obesity, low testosterone. And the other thing is that the penis and the heart have a fairly similar arterial supply, but the penile arteries tend to be a little bit smaller than the coronary artery. So here's a kind of size comparison there. So you've got the penile artery, the smallest, coronary artery a bit bigger, carotid artery even bigger, and the femoral artery even bigger than that. But if you imagine that they all get disease or mural thickening or atherosclerotic plaques, which one's going to have the problem first? Well, it's going to be the penile artery. And as such, ED may actually present earlier than other issues such as coronary symptoms or cerebrovascular disease or peripheral vascular disease. We think that coronary symptoms will often be around about 3 years earlier, 3 years later than the development of erectile dysfunction, and therefore they should be considered an early marker. Therefore, ED should be considered an early marker of cerebrovascular disease. And at the end of the day, they're probably the same systemic disorder. The risk factors are the same. The interaction between androgens and chronic inflammation leads to that atherosclerosis and flow-limiting stenosis. And there might be some other more less visible alterations such as endothelial dysfunction and autonomic hyperactivity that could be involved. So what do we do about it? Well, think about how you might look after a man, 65, age of retirement in some fields, probably not medicine anymore, who presents with erectile dysfunction and comes and sees you in the office. Might be a simple request for some Viagra, but it often gives you an opportunity to think about some more complex issues or more significant issues for that man. The sexual history is really important, and that's mainly to make sure that he's not talking about something that's unrelated to erectile dysfunction. So men often will get confused, and sometimes they'll want to actually talk to you about premature ejaculation or decreased libido or penile curvature, none of which are actually, and yet can still get really good erections. You want to know whether this is something that's only just happened recently or has been lifelong or progressive. You also want to ask about the psychosocial circumstances, elicit any signs or symptoms of the depression that may be either causative or secondary. Talk about all those risk factors and comorbidities that we've spoken about, medication history. At the end of the day, what effect their erectile dysfunction might be having on them. I often find someone who I would expect would want to have a happy, healthy, firm penis or a happy, healthy sex life, and they're just not interested. I often will see the 85-year-old man who will do anything to get an erection, including having surgery. And I'm always surprised that the person who's sitting next to me, unless you actually ask them what their goals are, will often either not tell you until you've asked them, and you'll often be surprised with what their goals are. Often I encourage the partners to come into the office so that you get a good sense of where the problems are and what can be done. When it comes to examination, general examination, looking for systemic issues, and then these are the things that you guys excel at: blood pressure, weight, height, waist circumference, really cardiovascular assessment. The genital assessment, there's really not too much that you guys can do in the office apart from making sure that there isn't a problem with the skin, or sometimes if patients present with ED and curvature, you can palpate a Peyronie's plaque. The investigations for just erectile dysfunction are relatively limited. They're cost effective, and they're pretty simple. So glucose lipid profile, morning testosterone. In young guys, you can consider prolactin and some other hormonal studies if you think that that might be a cause for their ED. But mainly it's, again, those cardiovascular risk factors. We'll talk about treatment in detail in a second, but at the end of the day, much of this you can manage in the office yourself over a number of consults, sometimes even just with one or two. Sometimes you'll need to send them to someone like myself, a urologist, but also that might be appropriate to send them off to an endocrinologist, a psychologist, or a sexual health physician, just depending on their issues. And so once you've done all this, you should be in a position to give them a very sensible management plan. And I therefore want you now to think of the opposite. So the guy that doesn't come in complaining about erectile dysfunction, but complains about everything else, especially those chronic cardiovascular patients. So it's often that guys will come in even with moderate to severe erectile dysfunction and not actually mention it. So the telephone survey of 40-year-old men and older say only 30% will actually talk to you about it. So you've got to ask. And that might be simple as saying, you know, many men of your age or your condition are at risk of sexual dysfunction. So I'd like to know if you've got questions or concerns about your sexual function, if you don't want to ask them directly. I have a little template in my software that basically forces me to ask them because I think I should, or it forces me to deliberately not ask them, which sometimes is appropriate, but most of the time I'll ask them. And again, like I said, I'm always surprised with what I hear. So what do we do? So we've got this man who's in front of us with erectile dysfunction and he wants a solution. We'll start with the simple measures first, optimize the modifiable risk factors and comorbidities. So the lifestyle, I mean, this is all obvious, and this is what I imagine you guys do far more than I, day in, day out. Smoking cessation, healthy diet, exercise, reduce alcohol intake, avoid recreational drugs, reinforce control of blood pressure, control of diabetes and hypercholesterolemia, and obviously assess in an ongoing fashion their cardiovascular risk. And then treat the reversible causes, which often aren't that many. So, you know, it's not that common that very low testosterone is the cause of ED, but replace it if it is. Medication-induced ED, consider alternatives for those medications, especially if they've, for example, an antihypertensive has brought on ED, consider using an alternative. Psychogenic erectile dysfunction, if you really think that that's the major component, then consider referral to psychologists, therapists, men's sexual health physician, and so on. Most men don't will then sort of be looking for a more concrete solution, and the traditional approach has been stepwise. So we start with the simple things and progress as appropriate. I guess on the bottom end of that ladder would be vacuum rings and vacuum devices and rings, PD5 inhibitors, which you're hopefully confident in using. Intra-Cavenosal injections are appropriate to be commenced in your office, or I'll often be starting that for men. And when we come to penile prostheses or vascular surgery, obviously that's where urologists need to be involved. So let me just remind you, if you've forgotten the mechanisms for the PD5 inhibitors, I want you to be very comfortable with using these medications. You don't need to send patients to me who are straightforward and simple to start PD5 inhibitors. You can be very confident in using these safely and effectively in your office. And so we've got a situation where the sexual stimulation of the nervous system releases nitrous oxide that stimulates GTP conversion to cyclic GMP, and that increases in the arterial smooth cell of the penile arteries. And that eventually leads to a decrease in calcium, which relaxes those muscle cells and allows more blood to flow into the penis, and you get your erection. The PD5 inhibitors work to basically break down cyclic GMP, and that's important to know, because what it basically tells you is that the PD5 inhibitors don't actually give you the erection. What they do is they help either maintain it or keep it stimulated or allow you to have it harder for longer, so to speak. And so they work at this step here, where they basically stop the breakdown of the cyclic GMP and keep the intracellular calcium levels low and the vessels dilated. But you still need the appropriate stimulation, the hormonal control, the nervous supply, and you still need good veins to stop the blood leaking from the penis when it's erect. These are the most, these are the only PD5 inhibitors available in Australia. There's a very good mix. They're all slightly different, but at the end of the day, very similar. The most common one that's been around forever is sildenafil, and it's fantastic that it's been around forever because it's off patent. And it's significantly brought down the costs of Viagra. So they're available in 25, 50, and 100 milligrams. And basically one tablet of the 100 milligrams top dose is down to $1.67. I checked on Chemist Warehouse last night. So it's an affordable medication. It can be used on demand, which is usually about an hour or two before intercourse. It's got a relatively short half-life, so it lasts for a 24-hour period, and it can be used on a daily basis. Cialis, or tadalafil, fantastically, just recently was made generic. It's obviously not on the PBS, but the price has come down drastically. The 20 milligram dose, which is what we use on demand, is $3.75. It's a little bit more expensive than Viagra, but because of its longer half-life, it will last for 2 or 3 days. So it probably ends up working the same. The other way we can take tadalafil is on demand, which is we can take it on a daily basis, which is using 5 milligrams, so the smaller dose, which is actually cheaper than Viagra per day, and at $1.07 a tablet. And that allows a little bit more flexibility, spontaneity in a younger man, for example, sex life, because he doesn't have to think about taking it beforehand and timing everything appropriately. The other good thing about Cialis, tadalafil, is that it also has some effect on lower urinary tract symptoms. We think there's a PD5 receptor, or we think that PD5s work on the bladder neck, and so men with mild lower urinary tract symptoms and erectile dysfunction, it might be a great option for them to have instead of tamsulosin, but start them on Cialis. And given that the cost is now basically similar, that shouldn't be an impediment. Levitra, which is vardenafil, and Spedra, which is avanafil, are both quite similar to Viagra, sildenafil. They're still on patent, so their cost, as you can see, is more. So Levitra, $14 a tablet, Spedra, $13 a tablet. The real tips to PDE5 inhibitors is to take them on a relatively empty stomach, because otherwise they just sit in the stomach, don't get absorbed. And 1 to 2 hours before intercourse, you've got to have appropriate stimulation. Anxiety can turn off any effect of these medications. So I normally encourage men to try them a couple of times and have low expectations initially. You can safely increase them to the maximum dose, and really before you say that they've failed, you should try at least using 2 different medications. So Viagra, Cialis, Viagra, Levitra, at least 2 different medications, because some men will get a good effect from one and not the other. Contraindications are pretty obvious. Nitrates, topical nitrates, people who have severe congestive cardiac failure, unstable angina, resting hypotension, a recent stroke or a myocardial infarction. Basically, anyone who really shouldn't be having sex probably shouldn't have PDE5 inhibitors. Side effects are relatively obvious, self-limiting, and will often turn men off a particular type of tablet, but might not be present if they use an alternative drug. So they might get some side effects from sildenafil, but not from tadalafil. So always mix it up if they do get side effects. The most common ones are headaches, flushing, dyspepsia, nasal congestion, all associated with dilatation of vessels. Viagra can cause some abnormal vision. Cialis can cause some backache and myalgia. But at the end of the day, I think you should be really comfortable in prescribing these. Men think they're fantastic. There's still a lot of stigma associated with using Viagra, and maybe we just use the trade name, becomes a little bit less. So if we use the generic name, it becomes a little less stigmatized. But they feel a little bit naughty sometimes, my patients, when they walk away with a script. But it's not that at all. I mean, these are good drugs, tried and true, and please prescribe them for the right patient. I want to run through some of the other things that you may or may not have tried. Vacuum erection devices are literally vacuum devices that go over the penis and pull blood into the corporal bodies. And then a ring is then lowered and fixed around the base of the penis. It requires a certain level of dexterity to do it, but it can often give a very suitable erection penetration. They're not necessarily loved by men. They're a little bit uncomfortable to use. It's not necessarily particularly sexy. There's some stigma in the press when you watch things like Austin Powers. Having a ring down on the base of your penis makes it difficult to ejaculate. You can get some bruising. The rings can be used alone. So if you get a good erection, but maybe have some venous leak, you can encourage men to use a ring. Some of these devices are available medicalized, so on medical websites, but some are just available in your local sex shop. And I often encourage men to go there or buy something online. If people go in, you know, the people who work in the sex shops are really knowledgeable, often see men with erectile dysfunction. And most of the time you can encourage guys to go in there and have a chat, especially if they want to see what's involved. Intra-Cavenosal injections are, you know, I often see men and they just pull the most horrendous face when you suggest that you might want to inject their penis. But the injection themselves is really just a very minor aspect of it that doesn't bother them. I will always do the first education session just sitting next to them in the office and let them do it themselves. I don't do it for them because it's easy. Cavaject Impulse, which is our Prostatectomy, is a fantastic drug. The penis has natural enzymes to it, so priapism is far less likely. There are some combinations of intracavernosal injections that are a little bit more complex, have a different advantages, like a little bit less pain sometimes when people get a firm erection, but they're a high risk of having problems like priapism. Fibrosis is a potential complication, about 2%. Pain is probably something that turns men off doing these injections, not so much the pain from doing the injection itself, but the actual stretching of the corporal bodies is quite uncomfortable. But it's a really effective way of bypassing some of those other roadblocks, for example, the nerve supply, or especially in the diabetic men who've got the peripheral neuropathy. It doesn't matter how much stimulation they can't get a good erection. We then come to some more surgical options. There's penile prostheses, and essentially this is putting a malleable, for example, what you can see here, it's not a man holding chopsticks, it's actually two malleable prostheses that are put into the corporal bodies. They're quite good for the older man who sort of just want something very simple. Dexterity is not great. They're not as rigid as an inflatable prosthesis, but they can work very well. They're also good, some of the older guys like them because if they've got a bit of a stumpy penis, it's hard to hold and always retracts in. This will help keep it out and a little bit more manageable for them. But what we often will come to is inflatable penile prosthesis. These are a great option for men. You get very firm erection. They're relatively easy to use. Satisfaction's high. There's good longevity, 5, 10, 15 years. There's a pump that sits in the scrotum and a reservoir that sits in the lower abdomen, and then two expanding cylinders in the corporal bodies. When it's decompressed, it's very comfortable, not noticeable for the patients, really, or obvious to anybody else. And so, for the people who've failed all these other treatments, it's a really good option. There's a couple of experimental options, and I'll just briefly touch on these. They're definitely not considered mainstream, although they can be marketed. They're marketed heavily in the United States, less so here, but I've still heard about them. So one's low intensity shockwave lithotripsy, basically using sound waves to have some effect on the arterial supply. There are some studies that support their use, but they tend to be small number of patients and short-term follow-up. So I think it's a bit of a watch this space rather than standard of care. And similar for platelet-rich plasma. These are establishing treatments. Patients can spend a lot of money on them, and they definitely should try some of the PD5 inhibitors first. So in summary, I hope you feel like you could be very proactive about erectile dysfunction because it's really important that you are. The key issues are it may be an early indication of cardiovascular disease. And as men are being diagnosed younger and living longer, they probably will start wanting something done about it. There are multiple and varied treatments available, and they should be guided by patient preference. And you can actually tailor the treatment to the patient. So not everyone will want everything, but there's usually a good fit somewhere along the line. Don't let patients be scared about surgery, because even though it sounds complex, there's some really good outcomes. And so if the lifestyle and medical treatments aren't working, send them along to see me or another interested urologist. Be very happy to look after them. And obviously we need your ongoing care to manage all their cardiovascular risk factors, and appreciate that. Thanks for your time tonight. Very happy to answer any questions.
Thank you, Dr. Jarvis. It doesn't look like we have any questions at the moment. Do you have any further comments to give people a chance to put in a quick question?
Oh, look, the guys who come and see me about erectile dysfunction are wide and varied. Often I just see that I find out about their erectile dysfunction probably like most of the GPs, almost as they're walking out the door. It's often not the reason why they come in, but it's something that is been heavily on their mind once they've started to think about going to a urologist. I've got a question here that says, are the prosthesis reversible? The answer is absolutely not. So when we put in a prosthesis, basically what we're doing is we're damaging the erectile tissue in the corporal bodies. So I usually limit a prosthesis to someone who is not able to achieve a good erection with other methods. So when I do penile prosthesis, the most common time that I do them will be, for example, after a radical prostatectomy, where erectile dysfunction, despite medication, despite injections, just not possible. I'll often do them in diabetic patients, patients with spinal cord injuries, and complex patients like that. It tends to be, therefore, in slightly older men. They're a great operation, one night in hospital. We wait until the scrotal swelling settles down over a couple of weeks before we get them to start inflating the device. But then when they do, they get a nice firm erection. And often these guys haven't had one for years, and they're really grateful. It's not something that's uncomfortable for them most of the time. They don't know it's there, and then just use them when they want it. Even some older men, if they've got a motivated partner, the partner can activate the device if, for example, their hand dexterity is not fantastic to squeeze on their scrotal pump. Yeah, they're not accidentally activated.
Okay, it looks like we aren't going to get any more questions. Thank you very much, Dr. Jarvis. That was very interesting.
No worries, Susan. It's been a pleasure.
Okay, thank you. Now we'll have Dr. Savdie. He is a urological surgeon, and he will be speaking on Peyronie's disease, stay ahead of the curve.
Great. All right. Good evening, everybody. Normally, I give talks about prostate cancer and PSA testing, but I thought I'd change it up this evening and talk to you about Peyronie's disease. This is a quite a common disease in the community, and so something that you may find interesting. I work at Prince of Wales, like Dr. Jarvis, and also St Vincent's Private, and I visit Goulburn once a month, if any of you are down in that area. So moving ahead to my next slide. So with Peyronie's disease, this can present in a few different ways. Obviously, you know, everybody knows that it's about curvature of the erection, but some men present with painful erection as their first presenting sign. They can also complain of hourglass deformity, failure of the distal portion of the penis to engorge. Sometimes they present with a lump that they're concerned about, and they're worried that it's a tumor or a cancer. And they can simply have erectile dysfunction as part of their presentation also. It's associated with some other conditions. Interestingly, Dupuytren's contracture, tympanosclerosis, plantar fascial contracture, all of these things, as you can imagine, have a similar etiology with a disorder of collagen scarring. They're also quite commonly associated with erectile dysfunction. So it is something to look out for in men who are expressing problems with their erections. Penile trauma is present in the history in 25% of men, and radical prostatectomy, unfortunately, is a big group that's emerging, probably because of their ensuing erectile dysfunction and possibly a penile trauma component also. If we look at some of the risk factors that have been identified, some of the other ones include you know, diabetes, hyperlipidemia, hypertension, all of those, you know, cardiovascular risk factors that might lead to a vascular cause for erectile dysfunction can also be complicit with this condition. Low testosterone is an interesting one. There is some association found in studies that needs further review, but something also to consider. So what is the natural history of this condition? So I will often be referred patients with this condition after it's been present for a few months. Probably 3 to 6 months is the most common time I get to see them. and they are in the active phase at that point. So the active phase lasts for about 12 to 18 months, and it's associated with pain in the penis, particularly with erection. And it is a time that the deformity, the curvature is progressing. Over that active phase period, we think that 15% improve, 40% have no change over that time once they've noticed the deformity, and 45% progress or get worse over that active phase period. They then go into a quiescent or stable phase after that, and that's usually when the pain stops and there's no further progression of deformity. So really, the active phase is the time when we want to institute medical therapies, and then once they're stable, if they're still disabled by the curvature, then that's the time to talk about surgery. So how do we evaluate them? So we identify whether they're in the stable or active phase. We look at their comorbidities. I get them to do a questionnaire such as the IIEF, which is a measure of their erectile function. The PDQ is the Peyronie's disease questionnaire, and that's the degree of disability that they have due to the curvature, and a lot of that is to do with pain, and it's to do with their ability to achieve penetration during intercourse. I often will ask the patients to provide images of the erect penis to get an idea of what we're dealing with. Often patients have already taken their own pictures for me when they come into the office, and they're very bashful about it, but you know, it is an important part of the assessment. And either we look at photographs, or we have to induce an erection in the office using something like CAVEJect to do it. So it's either one or the other. Stretch penile length just gives us an idea of whether the length of the penis has been compromised by the condition, and how long the penis is at the beginning of their journey, because that may become a factor if and when they come to surgery down the track. Investigations that can be useful, they're not mandatory, but I'll often organize a Doppler ultrasound of the penis with CAVEJect, and there's a radiology practice at St. Vincent's in Darlinghurst that will do this. And they're looking for what are the arterial waveforms like with erection. So is there, concomitant erectile dysfunction? But also they're looking at potential plaque within the tunica albuginea, and whether there's any degree of calcification within the plaque. MRI can be useful, particularly if you think there's deep plaque or septal plaque. So some men have, more than 90-degree curves, which is very disabling, and it means that they can't be sexually active. And for these men, obviously, they're going to go through a journey both of medical therapy and possibly of surgical therapy to try and fix it. So what are we talking about with plaque? Well, the penis has both the spongy erectile tissue in the corporal bodies, both left and right, but it's wrapped in what's called tunica albuginea, which is a dense collagen layer. The collagen layer, the tunica albuginea, is the area where the plaque develops, and as a result of this plaque, you get failure of lengthening, and then you get curvature either to the left or to the right, or dorsally towards the body, or even rarely ventrally towards the feet. So the ultrasound can demonstrate that plaque for you. It can look for calcification. As I said, in this ultrasound image, you can see calcification with posterior acoustic shadowing there, which is demonstrating a problem. And this one here on the right is showing a septal plaque between the two corporal bodies that's causing posterior acoustic shadowing. So hourglass indentations are particularly difficult to treat because rather than being unilateral, they're circumferential, or they're deeply embedded, and so they present a big challenge. So many oral therapies have been tried over the years, and as you can see here, you'll recognize a lot of these agents off the list. vitamin E, colchicine, tamoxifen, pentoxifylline. Unfortunately, almost universally, they're of no benefit whatsoever. So it's really not worth putting patients on any of these things. PDE5 inhibitors have been shown in recent years to be of benefit. So this study that was presented at the American Urological Association meeting looked at 3 groups of men. Firstly, one group that was injected with verapamil into the plaque, directly into the penile plaque. One group that had 5 milligrams of Cialis or tadalafil, and a third group that had both the injection of verapamil plus the Cialis. And they found that the 2 groups that received the Cialis did far better than the injection group alone, and they've inferred from that that Cialis is of benefit with this condition. Similarly, sildenafil, which is Viagra, obviously, they looked at a group that was injected with a drug called Xiaflex, and I'm going to talk about that in a minute, and the addition of sildenafil, and they found that the addition of sildenafil was created a significant improvement in curvature. Why is that? Perhaps the bolstering of erections, and we're talking about a group of men who often have poor erections, as I said at the beginning, that may result in a form of internal traction on the penis. So what are injection therapies? They're not that in vogue in Australia at the moment. You won't find many people doing them for various reasons. Lots of different things have been tried over the decades. In particular, verapamil, which is a calcium channel blocker, directly into the plaque to reduce fibroblast proliferation. Interferon, which has some benefit, but it's expensive. It can be associated with systemic side effects, and often it's very painful for the patient to inject, or to be injected, I should say, with this sort of drug. So that you may have heard about a drug called Xiaflex. This is a collagenase that's derived from Clostridium histolyticum. It's been used for Dupuytren's contractures for a long time. They performed 2 quite high-level studies looking at this drug versus placebo. And the way it worked was they injected the men they injected the plaque with the Xiaflex, followed by a modeling process where the men were instructed on stretching and straightening of the penis. So the idea is that you inject the plaque with this drug, it causes softening of the plaque, and then you remodel it through stretching and straightening. So they did a controlled trial where they looked at injecting with Xiaflex versus injecting with placebo. Both groups did modeling, and you can see that even though the drug arm had a 35% improvement in curvature, the placebo had a 18 to 20% improvement as well. So the modeling itself, the stretching and straightening exercises are of benefit in this condition. And unfortunately, Xiaflex is extremely expensive. It's now been withdrawn from the Australian market. It was costing patients $10,000 to $12,000 for 4 rounds of injections, and there's no reimbursement for it through Medicare or health funds. So it's fairly prohibitively expensive. It's also associated with a lot of complications, high rates of hematoma of the penis, a lot of pain, even penile fractures, things like that. So it's unfortunately not currently available in Australia. And so, it may reappear on the landscape in the future. Interferon, how does that compare to Xiaflex? Well, it's about 2/3 as good when it's been put in a comparison. But again, not great gains. Just to go back to my previous slide, if you're talking about a 35% improvement, you're not talking about a 35-degree angulation improvement. So if the patients have a 60-degree curvature and they have a 35% improvement, so they're getting to 40-degree curvature, right? So they're not ending up with a completely straight penis. And I think there's a lot of disappointment in the men from that, particularly with the expense of it, the pain and suffering that they go through with it over a long period of time. To only get a 30% improvement in their curvature, they weren't particularly happy with. So penile traction therapy is very in vogue at the moment. What's the idea that basically you're stretching the scar tissue, you're stretching good tissue, you're hoping for remodeling. And, there is some promise here. So penile traction therapy, the first generation devices, such as the andropenis on the left and the Penile on the right, they require, unfortunately, many, many hours per day for 6 months. They're uncomfortable to wear. They're difficult to conceal, so patients aren't that happy to wear them. And so they get inconsistent results because of that. And again, these are those same devices, the andropenis on the left and the Penile on the right. And, basically it's providing traction, pulling the penis away from the abdomen, and putting the tunica albuginea on stretch and putting the scar on stretch. So a new device has just come on the market. This is actually created by the Mayo Clinic in the US, a very reputable university hospital and medical center, and they've published their data in a reputable journal. So you can put more weight on this, I think. It's different from the others in that it allows bending of the penis around a fulcrum where you identify the plaque to be. For example, in this model penis, we're saying that the plaque is along the dorsal side, halfway down the shaft, and therefore by bending it to 120 degrees, you're putting extra stretch through that plaque area and getting better results. And certainly the data that they published in 2019 in the Journal of Sexual Medicine supports that. So this column graph is showing CCH, which is Xiaflex plus other penile traction devices, and Xiaflex plus Restorex on the right-hand column. And you're looking at 20-degree curvature improvement with the Xiaflex, and you're looking at 35-degree improvement with the Restorex. And this is a percentage here on the next graph along. And also they presented their stretch penile length data, and they're showing that, again, with the Restorex, the men are getting close to 2 centimeters increase in stretch penile length, or a 15-17% improvement as a percentage overall. So what is my first line treatment for men when I see them with Peyronie's disease in the active phase? I give them Cialis 5 milligrams daily, and I put them on traction therapy. I'm now encouraging them to get a Restorex if they can. A little bit more expensive than the other brands, but there's more science behind it. There's more data behind it. So I think it's worth the investment. And overall, studies have shown that despite the cost of the Restorex, it's a lot cheaper than other medical therapies such as Xiaflex or surgery even. So most men are happy to try it. Why do we do this as first-line therapy? Well, there's not much downside because Cialis, as Dr. Jarvis pointed out, is cheap now. If you take 5 milligrams a day, you don't get many side effects like the headache, flushing, etc., that you get with a full dose. And if you do traction, apart from the time investment, and I don't know if I said this, but the Restorex is only worn 60 minutes a day, rather than the 3 to 6 hours a day for the other traction. So it's much more manageable in that way. So you don't burn any bridges. There's not a lot of downside to doing Cialis and traction. And what you're trying to do during the active phase is prevent progression of deformity, obviously, and hopefully reverse it if you can. By the time they get to the stable or quiescent phase. So second line options then for curvature, if you aren't getting the results that you want with the first line therapy through the active phase, then once you reach the stable phase, there are a couple of options. And we'll start with penile plication. So this is really for men who've got a curvature of sort of 60, 70 degrees or less. The way it works is that you use suturing on the contralateral side away from the plaque, and you basically shortening that contralateral side to straighten out the penis. So you're using gathering stitches on the tunica albuginea underneath the skin to straighten the penis. And this is very effective. It'll get you a straight penis immediately. But the bad side is that you get reduced penile volume and effectively perceived length loss because of that. And that's usually 1.5 centimeters or so. Sometimes the men can feel the suture material under the skin. And, you know, you can get a modest recurrence of curvature over time if they get plaque progression. But generally a very solid surgical procedure. One other good thing is that it's not associated with worsening of erectile function in these men, which is very important. Moving on to the more complex surgery. So this is for men with greater than 70-degree curvature, when you're getting into that 90-degree plus sort of territory, and their curves are just too severe to be fixed with a plication technique, then you need to do something to the plaque itself. So that's either incising the plaque so that it will open out, or excising it by completely cutting it away. And when you do that, you're obviously creating a window in the tunica albuginea, which you then need to correct. And you do that by replacing it with a graft. This can be an allograft from the patient, such as a dermal graft that's harvested from their abdomen, or it can be a xenograft with a sterilized off-the-shelf material, such as a bovine pericardium. There are other commercially available things as well that you can then suture on as a graft. The good thing about it, again, you can straighten the penis very effectively with these techniques, and you don't get any length loss because you haven't shortened the contralateral side. If anything, you've lengthened their curved side, obviously. You can, however, there are some other downsides to it. You can have changes in sensation in the penis, are more likely than with plication. And you're also more likely to get erectile dysfunction after doing this. You probably because you've done something to damage their spongy erectile tissue below the tunica albuginea. Obviously, you have to be extremely careful not to do this, but these surgeries are associated with a higher rate of erectile dysfunction than with the plication surgeries. And then moving on, finally, excuse me, finally, for men who've got Peyronie's disease with associated, severe erectile dysfunction that's not responding to tablets or injections, as we spoke about earlier tonight, then those men are good candidates for a penile prosthesis up front, because you can then fix both problems at once. And basically, with the implantation of a penile prosthesis, you can then do what's called remodeling of the plaque while they're under anesthetic, and straighten out the penis at the same time. So there are treatments out there that are not supported by the literature. Shockwave therapy is not supported. Stem cell injections, PRP, these sorts of things are advertised by certain groups. Patients should not have these treatments because there's absolutely no benefit associated with them, so they're best avoided. So in summary, Peyronie's disease is very common, and it affects men significantly, both sexually and psychologically. There are many contributing factors to this, which we've talked about. And the treatment really depends on the goals. Often I tell patients that, really our goal is to keep them sexually active. If they've got a curved penis, but they can still use it, then we're happy. What we don't want to do is, by aiming for perfection, try and turn a curved penis into a straight one, only to find that it's not functional or usable, which would be the worst outcome. So we'll often accept a residual degree of curvature as long as it's functional. First line therapy, like I said, my go-to is Cialis 5 milligrams daily plus traction therapy now. And there's very little downside to that because there's few side effects. And then really not many men that I see end up coming to surgery eventually, because they're usually able to stabilize their curvature during the active phase. It remains functional, and really only the completely dysfunctional ones with, you know, greater than 60-degree curvature end up going for surgery down the track. So that's my talk. I'll open up, I guess, for questions now. I'll just bring up my questions here.
The first question we have is treatment for penile dorsal vein thrombosis.
Okay, so it's a good question. It's kind of separate from this talk, but it is something we do see a little bit. So these patients might present with a solid cord or cylindrical-like lesion running down the dorsum of the penis, and we think it might be a thrombosed vein. These patients I usually put on aspirin daily, you know, 100 milligrams daily of aspirin. And they can also rub Hiradoid cream, which is a thrombolytic sort of cream, into the vein to try and get it to dissolve. Rarely do we need to put people on, you know, low dose Clexane or subcut heparin to try and get it dissolved, and most of the time they resolve spontaneously. They'll often come on after a physical injury or a rough intercourse or something like that, and then that's how they present.
It doesn't look like we have any more questions. So thank you very much, Dr. Savdie.
Thank you.
We appreciate your time tonight and your talk. And we will now have Dr. Michael Lowy. He's a men's health physician, and he will be speaking on psychological aspects of sexual dysfunction.
Well, thank you for the other two speakers, and welcome everybody. I've been talking about this sort of area for a long time, but today I'm actually going to talk more about the psychological side of sexual dysfunction. As you know, I work in I work at back at my old name of Sydney Men's Health in the medical centre in Double Bay next to Woollahra Library. So everyone always talks, we've been dealing a lot with this part of the body today, but in fact we're going to talk a bit more about the brain, even though the brain and the genitals are very highly connected. It's never been as easy to get men to the doctor as it is to get women to the doctor. And as a result, their health problems are often much more advanced. And by the time they get there, things are a lot worse than they need to be. You know, that iceberg concept, when something gets just the tip of the problem's there, but there's a hell of a lot of problem underneath the water. Other thing about men who don't go to the doctor is they tend to, the waiting rooms are not... tend to be male friendly. They tend to sort of be a little bit overwhelmed by all the other stuff in the waiting room, and the whole idea is to make waiting rooms welcoming for men. The Andrology Australia introduced this whole concept of a men's health check, that guys should regard their body as their car, and they look after their car usually quite well, and they should look after their body in the same fashion. Now, men go through different health needs in their various decades of life. And of course, you know, the teens and 20s have issues around weight and physical fitness and STIs and testicular problems. In the 30s and 40s, they start to get the diabetes and blood pressure issues and, you know, weight gain and marital issues and mental health. In the 50s and 60s is when we get to the part I mainly see that, you know, the prostate problems, the prostate enlargement associated with erectile dysfunction, and these guys are often going through work issues, retrenchment, burnout, and they also have early parents that they're looking after, and the kids always end up coming back home in this age group, and that's always very stressful. And the senior years is all about, you know, weight control and bone care and cognitive function and making sure you have enough money in your superannuation. We always do talk to our patients about drinking. You know, it's still an issue. Some people do drink too much, and we all know that the new rule is 2 alcohol-free days a week, and no more than 10 standard drinks a week. And fortunately, very few men actually smoke these days. I'm very pleased to note that I hardly see any guys who smoke, and those that do still, you know, often smoke, you know, a pack a day or something like that. But this image here comes from the United Kingdom. which I think is a much better image than what we have on our packets of cigarettes. That normal male sexual response has been well documented over the years, particularly by Masters and Johnson. You know, it's the excitement, the plateau, the orgasm, and the resolution. Just to note, and I won't go into this in detail, the female sexual response is actually quite different to the male sexual response. It's a circular model. It's not a linear model, and it's a whole lecture in itself. Now, there's a lot of hormones associated with sexual functioning, and particularly around desire, excitement, and orgasm. And we can see a list of a whole lot of things here, including estrogen, progesterone, and testosterone, which are actually present in both sexes. When a guy gets an erection, it's usually some sort of stimulus, sends a nerve impulse, and through that cyclic GMP cycle, you get smooth muscle relaxation and nitric oxide and all that sort of stuff, and blood flows into the penis. Now that can be severely interrupted by psychogenic reasons, but particularly we see a lot of men who have performance anxiety. They just get anxious, and the worst thing what happens when you get anxious, your sympathetic tone increases, and there's nothing worse than trying to get an erection with a high sympathetic level, because that causes vasoconstriction to the penis, and that's one thing you don't want when trying to get an erection. So a lot of psychological issues with sexual function are based around increased sympathetic tone. We sort of call that psychogenic ED. We can try to divide men's sexual problems into ones around socio-cultural, political, economic factors, and that's about education, inadequate information on STIs, contraception issues. And the problems, next one of the problems due to the partner relationship, which often leads to inhibition of sex, avoidance of sex, distress, loss of interest. And the third one is the psychological factors, which is all about past negative experiences, guilt, shame, rejected. And the one down the bottom, the one I see, the fourth one is, as men age, there's a lot of physiological medical factors, and that's around health problems, medications, alcohol, and recreational drugs in younger men, and porn dependencies become a new issue, and something we do need to ask all our patients, and that can really impact on healthy sexual function. This slide, I'm just trying to explain in this slide, like the primary presentation in a man might be erectile dysfunction, but the secondary presentation might be premature ejaculation, because he's anxious and he has a performance anxiety. So it's often difficult when you see a guy who is anxious and has ED, what is the originating problem, because they often present together. And on the right, we can see that the primary presentation might be a guy who has premature ejaculation, but he might actually present, doctor, I've got ED. So these issues, the vascular-genic, the organic, physical ones and the psychological ones are so interconnected. So down the bottom one, I state, look, primary performance anxiety, if the guy's just anxious, he might just have ED or PE, but really not have any physiological issues. But the issue is that any man who has sexual dysfunction, it will bother him. And you see a guy who's bothered, and you actually don't know, is he bothered because he's got the sexual dysfunction, or he has the sexual dysfunction because he's anxious and he's bothered. So it often requires a fair bit of discussion and working out what really is the problem and what's happened in the past. So getting an erection involves chemicals that stimulate and chemicals that inhibit. So it's a little bit of a chemical balance here, just getting it right. And of course, it works better in younger people than older people. And this now leads on to this slide here, which is it's called the tipping effect. And when you're younger, everything is working so well, high levels of testosterone, blood flow, that the tipping is always in favor of the turning on. That's the green one on the left. As one ages, the balance is not quite so good. There's vascular issues, there's low testosterone, there's metabolic syndrome, and that tends to tip the balance of getting an erection in the wrong way. And this is often associated with anxiety as men struggle to keep their erection. Now, many years ago, a very clever Dr. Non developed implicit model of counselling, which is something that we and we're still used today. And it starts very simple, like just getting permission to talk. And if you've got a bit of, if you have a bit of understanding, you give some education, and then you can go more to specific suggestions of intensive therapy. Sexual function is all about arousal, and this comes from my colleague Rosie King's book. It often helps when a man or woman are struggling with sexual function is to create what we call a positive erotic focus, to think of something that's pleasurable, that turns them on, and it can be anything that they have experienced in the past or present. So there's becoming aroused involves physical changes, mental changes, emotional changes, and even spiritual changes. So there's a little bit of a process about dealing with the psychological issues around sexual dysfunction. Now, counselling has always been the mainstay, and we do so much try to get the partners into the office, and that's a picture of me many years ago, pretending I'm counselling. But it'd be always really nice if the partner comes with the guy with the problem, and I usually do suggest it for the second visit, but that doesn't always happen. But when you're taking a history, and every doctor knows how to take a history, we do all the usual things, the medical history, the psychological history, substances, stress factors, medications. But we need to get a little bit more detail when it comes to what is the problem. Now, men are very bad at explaining what's wrong with them. I've already said they don't know whether they've got ED or PE or performance anxiety. And you do need to ask a little bit of detail about exactly what's happening. And you do need to ask about the relationship and have they got a history of depression. And was it a sudden onset, which does suggest psychology? Was it a gradual onset? That suggests, physiology. When was your last sexual encounter? Are your erections firm enough for penetration? Has your level of desire changed? Have you got Peyronie's disease? Do you still wake up with erections in the night or in the morning? And if you self-stimulate yourself, is that as good as or bad as the erections you're having in a sexual situation? Now, sleep hygiene, snoring, sleep apnea has become a very big part of my work, because many men who have sleep apnea present with low testosterone and sexual dysfunction. In fact, as you know, that affects many different parts of the body. And younger men, I do not know any one younger person who does not use porn, but the problem with that is just when they become dependent on it, using it appropriately and occasionally is fine, but if they become dependent on it and can only self-stimulate with porn, when they're with another person, they get into a bit of difficulty. And we do need to ask about STIs, prostatitis, education in sexual matters, family attitudes, cultural issues, social factors, are young people allowed to bring their partners home, that sort of stuff. And of course, sadly, we do need to ask about physical, emotional, and sexual abuse. And sexual orientation, occasionally a young person comes to see me with classic sexual or erectile dysfunction, and it ends up that, there are issues about sexual orientation that often presents with, an actual erectile dysfunction. So when you see a guy who's got metabolic syndrome, and don't see too many people of this severity with those four aspects, you know that these guys are definitely going to have more than likely erectile dysfunction, and usually BPH, big prostates. It definitely goes hand in hand. Some time ago, we already developed this connection between erectile dysfunction, heart disease. We've already heard tonight that erectile dysfunction may be actually the predictor of coming coronary artery disease. There's lots of factors around these things, and the latest way of looking at this now is that erectile dysfunction is the same as endothelial dysfunction, and the whole connection between them all is the BPH, so heart disease, hypogonadism, diabetes, metabolic syndrome, sleep apnea. They're all connected, and so if one occurs, you've got to think of the other. And so they're even thinking that even though low urinary tract symptoms is often a marker for erectile dysfunction because they go together, it may well be a marker for cardiometabolic health. So and on top of all this, the guy may have a psychological distress over it, and you've got to work out what comes first. And I just want to mention a little bit about testosterone, because it's such an important part of male sexual functioning. And of course, we know that men have a lot more testosterone than women, but women need their small amount of testosterone, particularly, for their libido. And women's testosterone comes from their ovaries and adrenal glands, so they may still produce it after menopause, whereas most of the testosterone in men comes from the testes. And of course, as we've seen, men have a much higher level than women. And of course, the PBS authority rules you're only hypogonadal if it's less than 6, which we might argue against. And men who have low testosterone have the classic sexual symptoms and physical symptoms. They get fat, their muscles get weak. But the thing on the right here, the psychological thing, this is so close to depression. So men with low testosterone present with symptoms of depression, but men with symptoms of depression may get low testosterone. So it becomes a very clinical situation of working out, what is it? Is this guy depressed, or is he primarily or secondarily? And this image on the right is a classic hypogonadal guy, probably like a Klinefelter's type of presentation. So when a guy's got low testosterone, he actually feels like he's lost a tiger in his tank. His sense of well-being is lost, and that may also be confused with depression if he's got low testosterone causing that. Now, this slide comes from a colleague in the Netherlands, and it says that studies show that a guy aged 55 has at least 16 years more of sexual activity remaining, but in women it's 10 years. But the guy at 16 years, he's more than likely, due to the increasing incidence of ED as he ages, to not to be able to engage in the sexual activity that he would like to. So many men do continue well into their 70s and 80s, but it does tend to decline in the 70s, in the early 70s. So aging has a major impact on sexual functioning due to many factors around testosterone, libido, your physical health. Men start to experience difficulty reaching a climax. It's a classic issue that guys in their 60s and 70s complain to me that they just can't reach a climax like they used to. And there are also issues in women with low testosterone and vaginal dryness. So let's not forget our senior members who are just as entitled to a sexual response, sexual activity, I should say, like any of us. They have to put up with the negative attitude of sex, not being possible in older men and women, but intimacy is allowed at all ages. As a guy ages, this is total normal physiology. It just takes a little bit longer to get the erection, if you can get it at all. It takes a bit longer, it's more difficult to hold it. It needs a lot more stimulation. The orgasm's much less intense, and ejaculation may be only a few drops. The refractory period, the time it takes to have to get another erection and sexual activity, increases in time. It may be a day, a week, and of course these older guys have medical conditions, and if they don't use their penis for erections at that age, they can lose function just by literally by lack of exercise. Women have the same issue around aging, with slower arousal, less tactile sensitivity, needing more stimulation. The vagina and the cushioning of the urethra becomes not as soft and spongy as it used to be, and the orgasm less intense. So if you're going to look at sexual differences between older men and younger men, like younger men tend to have psychological problems causing sexual issues. Older men tend to be physiological. Of course, it can be either way, of course. Younger men tend to have a performance anxiety, even though they have a high libido, and older men their libido slows down. Younger men tend to have intimacy and relationship issues, where older men tend not to be as in the same level as younger men. But older men, their ejaculation is often delayed, whereas younger men, they just they may not have premature ejaculation, but they are generally quicker ejaculators. Now, GPs, there are barriers between GPs and patients actually talking about sex, and the patient may be embarrassed to talk about it, or may feel the doctor thinks he's too old to talk about it, or it's just normal for my age. And the GP may not regard an older person requiring a sexual history. GP may not feel comfortable with it, embarrassed, or have his or her own issues. So this is the classic example of the doctor saying, well, if my patient's got a problem, he'll talk to me about it, and the patient's saying, oh, I wish you'd ask me. So, if a patient has actually a medical conditions that are highly associated with ED, like, diabetes and metabolic syndrome and that, it'd be a nice question for the GP to ask, by the way, I see people with your health problems, and they also complain of sexual problems. Is that something you want to discuss? This one here is a classic situation, and I have experienced this many times in my working life, that suddenly an older guy comes wanting to have a script for Viagra, and clearly it's not an appropriate treatment, and it can be the presentation of early dementia, where suddenly, after years of low libido, no sexual activity with the partner, there's some drive to have sex again, and that it requires a very gentle treatment. So I just want to remind you a little bit about sleep apnea before I finish. So the Woolcock Institute has kindly provided me with this slide. Obstructive sleep apnea is such an unhealthy thing to have, and people can even have it without snoring, but usually it's the guys who snore and then they stop breathing and the partner gets terribly worried. But sleep apnea can be associated with low testosterone, depression, being tired, decreased libido, erectile dysfunction, and endothelial dysfunction. The actual loss of the smoothness of lung blood vessels, which creates erectile dysfunction. So everyone gets asked in my office about their sleeping patterns and if they're tired the next day. So I just want to remind you that the best source of information for anything we've actually spoken about tonight is Andrology Australia, which is now called The Healthy Male. Andrology Australia have finally got more funding from the government, and they decided to change the name because many people, the public, did not understand what andrology meant, but they're still just as good. They still have all the fabulous publications that you can get through them, and that's it. But I'll be happy to answer any questions if anyone's got them, or maybe Dr. Jarvis or Dr. Savdie.
Thank you, Michael. That was a great talk.
Oh, thanks, Richard. Yours is
always
good
nice
too.
to hear colleagues talk about these things, because surgeons and sexual health physicians have a lot of overlap, or urologists and sexual health physicians have a lot of overlap. And I often feel when I'm sitting in a consultation with men talking about their sexual function that I'm out of my depth a lot of the time, because most of my training as a urologist didn't revolve around that area. But the longer you're in practice, the more you see it, and I guess you learn as you go. And no doubt there's a lot of GPs listening tonight that have spent a lot of years talking to patients about their sexuality and their sexual function and different aspects of what we've talked about tonight. And so everybody's got their expertise to share, but it's certainly nice to have people like Dr. Michael Lowy around, who you can go to for that extra experience and wisdom. So thank you. I don't know, I think I scared everybody off with my Peyronie's talk. Let's see if there's any questions here.
Richard, can I ask you, just with Peyronie's, I know that all those drugs are not don't have a lot of proof, but I have been using Trental for some years because we've had very little drugs to use, and right. The trouble is, many Peyronie's get better on their own, and when the guy's on Trental and it gets better, you think, oh, good, I'm treating him well. So I'm not sure if it's something I shouldn't be prescribing anymore.
Yeah. Have you noticed any negatives from taking it? I guess that's the thing, isn't it? We always sort of want to weigh up the pros and cons of a treatment. What are the side effects? What are the costs to the patient? That sort of thing.
No. In fact, they just have to take it with food because it can upset their stomach. I just give it 400 milligram twice a day. And I know it's a weird drug for Peyronie's, but I have a sense that it might work. But that's because some Peyronie's actually get better.
They do, yeah.
I like your summary. I think it's very simple what you said, like 5 milligram of tadalafil daily, and traction device. And I think that's a really good idea, because there's that guy in America, Levine. He's a real proponent of traction devices, and I think that's the way to go.
Yeah, look, they're simple, and there's not a lot of downside. And what you don't want to do is do something to a man that's going to make them worse. I think what happened with the injections, even though they do work and the studies show that, they do cause a lot of complications, a lot of side effects, and they're painful and it's uncomfortable to go through. And the reality is with a Peyronie's plaque, it's a hard bit of fibrous tissue, it's calcified, and trying to put a needle in it and inject liquid into it is inherently difficult. So for that reason, they're just not great. But look, I think I don't have a lot of experience using Trental because since I've been in practice, there's been evidence for tadalafil, so I've been doing that. But I definitely take that on board, and because particularly, for example, with the young men who don't have erectile dysfunction, you feel a little bit uneasy putting them on Cialis because you think, well, these guys don't have a problem with their blood flow, they've got good erections, and yet they've developed a plaque, maybe through trauma or something like that. So perhaps that'd be a good option for a younger man. Yeah.
We've got 3 questions have come in. One's for Tom, one's for me, and one's for you. Richard, is there an equivalent disease process to Peyronie's that occurs in women?
Well, I don't think you'd say it's equivalent, but certainly women can get problems with vulval skin diseases that cause a similar degree of disability, and they that is called lichen sclerosis, for example, where you'll have vulval atrophy leading to problems with intercourse and so on. So I think that would be the closest comparator, but certainly the Peyronie's plaque is quite unique because of its effect on the tunica albuginea. And
I got asked, what can you tell older men who are interested in intercourse but their wife is not? And well, that's a lot, but I also see the opposite too. I see men who are not interested and their wives are. These are complex psychological problems, but if we're going to generalize, we could say that women tend to lose interest in libido after menopause, after they've had their kids, and that's sort of more like an evolutionary thing, whereas men, in some cases, despite age and lowering testosterone, tend to continue on their journey to have continuous sex. It can get very complicated. What I talk to my couples about as they age, I talk about intimacy and pleasuring as opposed to sexual intercourse, because people think sexual intercourse is just the traditional getting an erection into a vagina. But we say let's just look at now. Okay, you're older, things have changed. There's a lot more touching, pleasuring needed. That may involve genital touching, it may not. And so we try to become more general about how people engage in sexually. So we actually call that outer course as opposed to intercourse. So I really encourage people to continue with outer course if intercourse is not possible. And we got a question for Tom. Can you comment on the treatment options for ED in men post-prostatectomy? I think we could both talk about that, Tom.
Yeah, we definitely could. And that's what Richard was saying. There's this huge overlap. Absolutely. I mean, a lot of the strategies are similar. So, but they're in a group of patients that have had major surgery. Sometimes have also had radiation, who may also have incontinence, which really bothers them during sex, or might stop them from even worrying about their erections once their continence can be managed appropriately. And these guys, for example, can have leakage of urine with arousal, or climacturia, which is leakage of urine on orgasm. And so I find that I still have to go through the basic steps, see what they want, see if they've got any other risk factors that can be modified, make sure they've tried or have failed the PD5 inhibitors. I tend to be a little bit faster to go to injections and prostheses for these guys, because you know, by about 12 months, they're not going to get a huge amount of return of function from what they've got at that point, especially if they had good erections before. So trying to kind of drag it out and see how they go for years and years probably actually does them more harm. Their erectile bodies don't get expanded. There's damage to their corporal tissue. They lose penile length, all the things that will make them unhappy when they actually do get onto it. There's, you know, the big centers in America almost do it too much the other way. They make each man obsessed by having an erection around the time of having surgery for prostate cancer. You know, they're doing prehab and then rehab, and if you're not having an erection within a short period of time, you should be on the medications and the injections, and it's very overwhelming. And unsurprisingly, there's a huge number of implants that are placed in the United States, whereas in Australia, I think Aussie guys are a little bit more lackadaisical about it, you know. I don't know what you think, Michael. Maybe not the ones that you see, but yeah.
Well, Dr. Lim has asked, what's the estimate cost to a patient? How much? Yeah,
so look, at Penile Prosthesis, so a while ago, they basically, along with a couple of operations that I guess had a quality of life or cosmetic aspect to them, they were. I can't readily perform penile prosthesis surgery in the public hospital. They just don't let me. Number one, they don't want to pay for the prosthesis, which is around about $10,000 to $15,000 just for the equipment, and they don't actually let me put it in. The only times they've ever done it if I'm revising a complex case, or if they've been put in for a really unusual reason initially, and then they've failed and they just need a replacement. So as a result, most penile prostheses happen in the private system. If you're in a health fund, just like any private surgery, the prosthesis is all covered by the health fund, and then there's the cost of the excess that you need to pay for the hospital visit, the surgeon's fee, and the anaesthetist fee. And you know, I won't go into specifics because that's very different for every surgeon, but you know, I like to think that, you know, this is an important part, and men shouldn't be priced out if they've got health insurance. They shouldn't be priced out of having something that really can be life changing. The only thing that I will say is that malleable prostheses are significantly less expensive. And so, for example, the one that you saw in my presentation is sort of, you know, $10,000 to $15,000 at $800. And so, you know, you can, if someone didn't have insurance and wanted a malleable, you can kind of come into the private system, have a malleable prosthesis at a much better price point if they haven't been, you know, been paying the subscription for the health insurance. The other thing is just pay health insurance for 12 months and then you're covered. So most of these guys have had ED for longer than 12 months, and many of them are happy to wait. I wish we could offer it in the public. There's lots of people that really can't afford it, can't afford paying health insurance, let alone, and they're just priced out.
Concord Hospital was the last hospital to do public prostheses, and they stopped about 10 years ago.
Yeah.
I'd like to thank you all very much for taking the time to present tonight, and I'd like to thank everyone for attending. Welcome Anna McGlynn from Health Pathways for a quick update on Health Pathways. Thank you.
Thanks, Susan. I'll just quickly share my screen. So yeah, I'm Anna from Health Pathways. Thanks for having me. I won't take long at all. Just letting you know that South East Sydney and Sydney Health Pathways, these are our login details. Please use your phone and use the QR code if you haven't used Health Pathways before. We share our username and password, so if you have one, you can get into the other site and you can Google us quite easily. South East Sydney don't have any of the pathways for what you are listening to tonight, but the Sydney Health Pathways team definitely does, and some other relevant ones as well. So jump on and have a look. It helps you manage the clinical condition and also know where to refer to. And these are the contact details for both the SES and the Sydney Health Pathways team. So if you have any questions for the team, please get in touch. And on every pathway, there's a little message icon. You can send us feedback using that at any point of time. Thanks.
Thanks, Anna. Thanks very much. So again, I'd like to thank all our speakers for tonight, and thank you all